Welcome to Bookfulness. This is our third deep dive into Moore's Clinically Oriented Anatomy, ninth edition.
That's right. And if you joined us last time, we covered quite a bit the muscular, cardiovascular, lymphoid, and the sort of general structure of the nervous systems.
Exactly. So today we're reaching a really important point in the text. We're going to wrap up the foundational concepts in Chapter 1.
We are. We'll be looking at pages 179 to 199, which covers the autonomic nervous system and medical imaging, how we actually see inside the body.
And then, crucially, we make the jump into regional anatomy. We're starting Chapter 2, looking at the back and the vertebral column, specifically pages 200 through 208.
It's a big transition, moving from the systems view to how everything is actually laid out region by region.
So our mission today is kind of twofold. First, tackle that last big systemic piece, the involuntary nervous system, and understand the tools we use to visualize anatomy.
And second, to build a really solid foundation for the axial skeleton, particularly the vertebral column. This is the language, the framework you'll need for all the regional chapters that follow.
We're basically extracting the must-know info that unlocks the rest of the book. Okay, let's get started.
Right. First up, the autonomic nervous system, or ANS. Think of this as the body's visceral motor system. It's running things behind the scenes.
The stuff we don't consciously control, like smooth muscle in our gut, glands secreting hormones, that kind of thing.
Precisely. Smooth muscle, glands, and also that specialized cardiac muscle that keeps the heart beating rhythmically. It's your body's background operating system, essentially.
Now, I remember this being a sticking point for a lot of students. It's different from the nerves controlling, say, skeletal muscle movement, isn't it? There's a key structural difference.
There absolutely is, and this is the fundamental rule you have to grasp for the ANS. Unlike the single neuron pathway from the CNS to a skeletal muscle, ANS conduction always involves a two-neuron series to get from the CNS to the target organ.
Always two neurons. Why that extra step? Why the relay?
Well, that relay station, the ganglion, is critical. It allows for modulation for integration of signals outside the direct line from the brain or spinal cord, and it lets the body use different chemical signals to create either really widespread effects or very targeted, localized ones.
Okay, so break down the two neurons for us. The first one.
The first one is the presynaptic neuron, sometimes called the preganglionic neuron. Its cell body, its control center, sits entirely within the gray matter of the CNS, either the brainstem or the spinal cord.
So it originates in the CNS, its axon then travels outwards, but it doesn't go straight to the target muscle or gland, right?
Correct. Its axon reaches out from the CNS, and its sole job, its only connection point, is to synapse onto the cell body of the second neuron in the chain.
And that second neuron is the
postsynaptic neuron, or postganglionic. And here's the crucial anatomical point. The cell bodies of these neurons are found outside the CNS. They're clustered together in structures we call autonomic ganglia.
So the ganglia are like relay stations outside the main highway of the CNS.
Exactly. And it's the axon of this postsynaptic neuron, the postganglionic fiber, that actually travels the final distance to innervate the effector organ, the smooth muscle cell, the gland cell, whatever the target is.
Got it. Two neurons, synapse and a ganglion outside the CNS. That's the absolute core structure of the ANS.
Nail that down and you're halfway there. Now, the ANS itself is divided into two major divisions, which often have opposing effects. We've got the sympathetic and the parasympathetic.
Let's start with the one everyone knows, the fight or flight system, the sympathetic division. The book also calls it the thoracolumbar division.
And that name, thoracolumbar, tells you almost everything you need to know about its origin.
How so?
Because the cell bodies of the presynaptic sympathetic neurons are found only in very specific parts of the spinal cord gray matter, the intermediolateral cell columns, or IMLs. And these IMLs only exist between spinal cord levels T1 down to about L2 or maybe L3.
Okay, so T1 to L2, L3. That's a surprisingly limited stretch of the spinal cord.
It is. If a sympathetic nerve signal is starting its journey out from the spinal cord, it has to originate somewhere in that thoracolumbar zone.
But wait, the effects are body-wide, aren't they? If you get a fright, your heart pounds, you sweat, your pupils dilate. That's not just happening in your thorax and upper abdomen. How does that T1L2 signal get everywhere?
That's the cleverness of the system's wiring. The presynaptic fibers exit the spinal cord with the regular motor neurons in the anterior root, but then they immediately branch off and head towards those autonomic ganglia we mentioned. And there are two main types of ganglia where they can synapse.
Okay, what are the two types?
First, you have the paravertebral ganglia. Imagine two chains of beads running vertically, one on each side, right alongside the vertebral column. These chains are the sympathetic trunks. They extend all the way up into the neck and down into the pelvis.
Paravertebral alongside the vertebrae. Makes sense. What's the second type?
The second type are the prevertebral ganglia. These are located further away from the spine, out in the abdominal cavity. They tend to cluster around the roots of the major arteries branching off the abdominal aorta, like the celiac trunk or the mesenteric arteries.
So paravertebral close to the spine, prevertebral further out near the gut arteries.
Precisely. Now, back to your question about widespread effects from a limited origin. The key is divergence at the ganglion.
Divergence, meaning one signal splits.
Dramatically so. A single presynaptic sympathetic fiber entering a ganglion might synapse with 30 or even more postsynaptic neurons. Think about that amplification. One nerve fiber from T1 can trigger responses in dozens of downstream fibers.
Wow. Okay, that explains the potential for a massive body-wide response from that central T1L2 outflow. It's like hitting one switch that turns on lights all over the building.
That's a great analogy. Now, let's trace the journey. How does that T1L2 outflow actually reach, say, your arm or your head, which are clearly outside those spinal segments? When a presynaptic fiber enters the sympathetic trunk, it has basically four options, according to the text.
Okay, option one.
It could synapse right away in the ganglion at the same spinal level it entered. Simple enough.
Option two.
It could travel up the sympathetic trunk, ascending maybe several segments, before synapsing in a higher paravertebral ganglion, like one of the cervical ganglia that supply the head and neck.
Option three.
Predictably, it could travel down the sympathetic trunk, descending to synapse in a lower paravertebral ganglion, perhaps in the lumbar or sacral region, to supply the lower limbs or pelvic structure.
Right. Up, down, or synapse immediately. What's the fourth option?
Option 4 is crucial for the internal organs. The presynaptic fiber can pass straight through the sympathetic trunk ganglion without synapsing at all.
It doesn't relay in the trunk. Where does it go then?
It continues onward, typically bundling with other fibers doing the same thing, to form what we call splanchnic nerves. These splanchnic nerves travel out to those prevertebral ganglia we mentioned earlier, the ones sitting out by the abdominal aorta. That's where they finally synapse.
Ah, so the splanchnic nerves are basically bundles of presynaptic fibers heading out to the prevertebral ganglia to control the abdominal organs.
You got it. That fourth pathway is the main route to the gut, kidneys, and so on.
Okay, so we've got the presynaptic fiber synapsing somewhere. Now, what about the postsynaptic fiber getting to its final destination? Let's take the body wall and limbs first. How do they get there?
This involves traveling back to the spinal nerve. Postsynaptic fibers originating in the paravertebral ganglia, the sympathetic trunk, need a way back to the main road, so to speak. They use specific connecting branches called the gray rami communicantes.
Gray rami. I remember white rami too. What's the difference?
Good point. The white rami communicantes are the on-ramps. They carry the myelinated presynaptic fibers from the T1, L2, L3 spinal nerves into the sympathetic trunk. That's why white rami only exist at the T1, L2, L3 levels.
Okay, white rami bring the signal in at T1, L2, L3.
Then, the gray rami communicantes are the off-ramps. They carry the unmyelinated postsynaptic fibers from the sympathetic trunk back to the spinal nerve. And here's the kicker. Gray rami connect the trunk to every single one of the 31 pairs of spinal nerve.
Every single one.
Yes.
C1 down to the coccygeal nerve.
Every single one. That's the distribution mechanism. The sympathetic signal originates only in the thoracolumbar region, travels up or down the trunk, synapses, and then the postsynaptic fibers use the gray rami to hop onto all spinal nerves, cervical, thoracic, lumbar, sacral, coccygeal, to reach the entire periphery.
So that's how my fingertips get sympathetic supply for sweating and blood vessel control. Even though the signal started way up at T1, it piggybacks on my cervical and brachial plexus nerves via the gray rami.
Exactly. It allows that limited T1, L2 outflow to control blood vessels, sweat glands, and those tiny erector pili muscles that cause goosebumps virtually everywhere in the body wall and limbs. The only exceptions are truly avascular tissues like cartilage and nails.
Makes sense. What about getting signals up to the head? Structures like the eye, salivary glands?
That primarily uses option 2 from our list. Presynaptic fibers ascend the trunk to the superior cervical ganglia at the top of the neck, but then the postsynaptic fibers don't use gray rami to join spinal nerves. Instead, they form cephalic arterial rami.
Cephalic arterial rami.
Yeah, they essentially wrap themselves around the major arteries heading into the head, like the carotid arteries. They form these intricate networks called periarterial plexuses and just follow the arteries to reach their targets: iris muscles, glands, blood vessels in the head.
traveling along the arteries like little nerve highways. Clever. And for the gut viscera.
That was option 4. Presynaptic fibers pass through the trunk, form splenic nerves, synapse in the prevertebral ganglia near the aorta. Then the postsynaptic fibers form their own periarterial plexuses following the branches of the abdominal aorta, like the celiac, superior mesenteric, inferior mesenteric arteries, out to the stomach, intestines, kidneys, etc.
Okay, it's complex, but the logic is there.
Yeah.
Central origin, divergence in ganglia, and multiple distribution routes, spinal nerves via gray rami, arteries via cephalic, periarterial plexuses.
You've got the core pathways. Now there's one famous exception we absolutely have to cover, the suprarenal gland exception.
Ah, yes, the adrenal gland. What's special here? It breaks the two-neuron rule, doesn't it?
It does, in a fascinating way. The suprarenal gland sits on top of the kidney, and it has an outer cortex and an inner medulla. The sympathetic supply targets the medulla. Here's the exception. Presynaptic sympathetic fibers, traveling typically in the splenic nerves, pass through the prevertebral ganglia without synapsing and go directly to the medulla of the suprarenal gland. They synapse directly onto the cells within the medulla.
So they skip the postsynaptic neuron entirely. There's no ganglion outside the gland.
Correct. Functionally, the cells of the suprarenal medulla are the postsynaptic neurons. They've just become highly modified. Instead of releasing norepinephrine onto another nerve fiber or a local effector cell, these medullary cells release their neurotransmitters, primarily epinephrine, adrenaline, and some norepinephrine directly into the bloodstream.
Ah, so it converts a nervous signal directly into a hormonal signal.
Exactly. It's a neuroendocrine link. This allows the sympathetic system to trigger a widespread, longer-lasting hormonal alarm state that reinforces the direct neural fight-or-flight effects. It's a brilliant design for amplifying and sustaining a systemic response.
That is pretty neat. So, quick structural summary for the sympathetic system. The ganglia are relatively central, paravertebral or prevertebral, meaning the presynaptic fibers are generally short, and the postsynaptic fibers have to travel a long way, so they're relatively long.
Perfect summary. Now let's flip to the other side, the parasympathetic division, also called the craniosacral division, the rest and digest system.
Craniosacral. Okay, so following the naming logic, the origin must be in the cranium and the sacrum.
Precisely. The presynaptic cell bodies are located at the two extreme ends of the CNS. The cranial part is in the brainstem, associated with specific cranial nerves. The sacral part is in the spinal cord, but only in segments S2, S3, and S4.
Which cranial nerves carry parasympathetic outflow?
There are 4 key ones: cranial nerve third, oculomotor for pupil constriction and lens focus, CN7, facial for lacrimal and salivary glands, CNIX, glossopharyngeal, mainly for the parotid salivary gland, and the big one, CNX, vagus.
Vagus nerve. That one wanders everywhere, doesn't it?
It really does. The vagus nerve is the workhorse of the cranial parasympathetic system. It provides the parasympathetic innervation to basically all the thoracic organs, heart, lungs, bronchi, and most of the abdominal organs, stomach, small intestine, liver, pancreas, kidneys, and the large intestine down to about the left colic flexure. It's incredibly extensive.
Wow, so if the vagus covers the thorax and most of the abdomen, what's left for the sacral outflow? S2, S4.
The sacral outflow takes care of the distal end of the system. It innervates the descending colon, sigmoid colon, rectum, and all the pelvic viscera, bladder, uterus, erectile tissues. Think about functions related to emptying, defecation, urination, sexual function. That's primarily the domain of the sacral parasympathetics.
Okay, so craniosacral origin, very different targets from the sympathetic system's global reach. What about the structure, the fiber lengths? Is it the same two-neuron setup?
Still 2 neurons, still a ganglion, but the arrangement is almost the mirror image of the sympathetic system, designed for precision, not mass action.
How so?
In the parasympathetic system, the presynaptic fibers are typically very long. They travel almost all the way from the brainstem or sacral cord right to the doorstep of the target organ.
Long presynaptic fibers. So where are the ganglia?
The parasympathetic ganglia are usually tiny, sometimes microscopic, and they are located either right on the surface of the target organ or actually embedded within the walls of the organ itself. These are called terminal ganglia or intramural ganglia.
Ah, so if the ganglion is right at the target, that means the postsynaptic fiber must be
Extremely short, often just traveling a few millimeters within the organ wall to reach the smooth muscle or gland cells.
Okay, so long presynaptic, short postsynaptic, that's the complete opposite of the sympathetic, short pre, long post setup.
Exactly, and that anatomical design, long presynaptic fibers reaching specific targets, Synapsing in local ganglia with very short postsynaptic fibers is what allows the parasympathetic system to exert fine-tuned, localized control over individual organs without triggering a massive body-wide response.
It prevents crosstalk. You can stimulate digestion without affecting your heart rate, for example.
Precisely. If the sympathetic system is like a general alarm bell, the parasympathetic system is like having individual dimmer switches for each room.
That's a helpful way to think about it. Now, the book also briefly mentions the enteric nervous system. Where does that fit in?
The brain of the gut. It's increasingly recognized as almost a third division, though heavily influenced by both sympathetic and parasympathetic inputs.
So it's not just receiving orders.
No, it's this incredibly complex mesh-like network of neurons located entirely within the walls of the digestive tract, from the esophagus down to the rectum. It contains perhaps as many neurons as the spinal cord. It can independently control gut motility, secretion, blood flow. Complex reflexes happen entirely within the enteric system.
So the sympathetic and parasympathetic nerves just modulate its activity, like turning the volume up or down.
That's a good way to put it. They provide external influence, speeding things up or slowing them down, but the enteric system has its own intrinsic circuitry. Moore's highlights its unique status.
Okay. Lastly, for the ANS, let's touch on sensation. We know the ANS is primarily motor, but organs do send signals back, right? Visceral sensation.
Absolutely. Internal organs have sensory receptors that monitor stretch, chemical changes, temperature, and importantly, tissue damage or irritation, which we perceive as visceral pain.
And this is where the concept of referred pain comes in, isn't it? Like heart attack pain being felt on the arm. How does that work anatomically?
It's all about pathway convergence in the spinal cord. Visceral sensory fibers, especially those carrying pain signals, often travel back towards the CNS alongside the sympathetic motor fibers.
So they follow the sympathetic nerves back to the T1, L2, L3 region.
Many of them do, yes. And when they enter the spinal cord, these visceral efferent fibers synapse on the same second-order neurons in the gray matter that are also receiving sensory input from the body wall, the skin and muscles of a particular dermatome.
So signals from the heart and signals from the skin of the arm might land on the exact same neuron in the spinal cord.
That's the issue. The brain, which is much more accustomed to interpreting signals coming from the body surface, somatic sensation, gets this strong signal from the shared neuron. It can't easily distinguish whether the origin was the internal organ, visceral, or the body surface, somatic, that also uses that pathway.
So it defaults to thinking the pain is coming from the more familiar source, the skin or muscle.
Often, yes. It refers the sensation to the dermatome corresponding to that spinal cord level. For the heart, the afferents typically enter around T1, T4. Those same spinal segments receive somatic sensation from the upper chest and the medial side of the left arm. So cardiac pain is often referred as pain in the chest and left arm.
Understanding that convergence is key to interpreting so many clinical presentations. Gallbladder pain referred to the right shoulder, kidney pain to the flank. It's all about shared spinal pathways.
Exactly. It's a crucial piece of applied neuroanatomy.
Okay, we've covered the intricate wiring of the ANS. Now let's shift gears to how we actually visualize all these structures and pathologies within a living person.
Right. We're moving into radiologic anatomy. And it's vital to understand this isn't just looking at static pictures like in a dissection manual. We're seeing anatomy in vivo.
What difference does that make?
A huge difference. You see the effects of muscle tone holding things in place, fluid pressures, distending cavities, the pull of gravity. Things look different than they do in a preserved cadaver laid flat on a table. Plus, we can often see function, not just structure.
Okay, so let's start with the oldest and maybe still most common technique, conventional radiography or basic X-rays. How do they work again?
It's fundamentally about differential absorption. An X-ray beam passes through the patient towards a detector, film or digital. Tissues absorb or block the X-rays to different degrees based on their density and thickness.
And the image we see is basically a shadowgram of that absorption.
Precisely. And we need the right terminology. Dense materials like compact bone or maybe a metal foreign object absorb most of the X-rays. Very few reach the detector behind them. This area appears bright or white on the image, and we call it radiopaque.
Radiopaque means white or bright, blocks X-rays, like bone.
Correct. Conversely, materials that are not dense, like air in the lungs or gas in the bowel, let most of the X-rays pass straight through to the detector. This results in a dark or black area on the image, which we call radiolucent.
Radiolucent means dark or black, lets X-rays pass through, like air.
Exactly, and everything else falls on a grayscale in between. Fat is relatively radiolucent, dark gray, while soft tissues and water are intermediate density, lighter gray. It's this contrast between densities that allows us to see structures.
But the big limitation of a standard X-ray is that it's a 2D image of a 3D object, right? Everything gets squashed onto one plane.
That's the fundamental challenge, superimposition. Structures lying in front of or behind the area of interest get projected onto the same spot in the image, potentially obscuring details or creating confusing shadows.
Which is why you almost always need more than one view.
Absolutely essential. Standard practice usually requires at least two views taken at right angles to each other, typically an AP or PA view and a lateral view. This allows you to mentally reconstruct the 3D location of something like pinpointing exactly where a fracture fragment is.
Let's clarify those projection terms. PA projection.
PA means the X-ray beam travels from posterior to anterior through the patient. The patient has their chest against the detector and the beam comes from behind them. This is the standard for chest X-rays because it minimizes magnification of the heart.
And AP projection.
Anterior to posterior. The beam enters the front, exits the back. This is often used for portable X-rays when the patient can't stand, like in the ICU, but it does tend to magnify structures further from the detector, like the heart.
Okay, PA and AP define the beam path. What about how we look at the image once it's taken? Is there a standard convention?
Yes, and this is critical for consistency. Most standard radiographs of the body, chest, abdomen, pelvis, limbs are viewed as if the patient is standing in anatomical position facing you. It's an anterior view.
So even if it was a PA projection, I view it as if they're facing me, meaning the patient's right side appears on my left.
Correct. The patient's right is on the viewer's left, patient's left on the viewer's right, always. For lateral views, they'll usually mark which side, R or L, was closest to the detector.
Got it. Standard viewing is patient facing you.
Yeah.
Now, what if the structures you want to see don't have enough natural density difference, like the inside of the stomach or blood vessels?
That's where contrast media come in. These are substances that are highly radiopaque, or sometimes radiolucent, though less common, that we introduce into the body to outline structures that wouldn't normally be visible.
Like drinking barium sulfate for an upper GI series.
Exactly. The dense barium coats the lining of the esophagus, stomach, and duodenum, making their lumen, their internal space and contours, appear bright white on the X-ray. Or we can inject iodine-based contrast into blood vessels, angiography, or into the urinary system, urography, to visualize them. Contrast agents dramatically expand what we can see with conventional X-rays.
Okay, so X-rays give us 2D density maps, often enhanced by contrast. But to really beat superimposition, we need slices. That brings us to computed tomography, or CT.
CT was a game changer. It still uses X-rays, but in a much more sophisticated way. An X-ray tube rotates around the patient, shooting thin beams through a slice of the body from many different angles. Detectors on the opposite side measure how much radiation gets through each beam path.
And then a computer does some magic.
Pretty much. A powerful computer takes all those absorption measurements and uses complex algorithms to calculate the radiodensity of tiny volume elements, or voxels, within that slice. It then reconstructs these voxel densities into a cross-sectional image.
So you get an actual slice, like looking at an anatomical cross-section. No superimposition.
Exactly. You see the anatomy in that plane clearly. You can see the liver distinct from the kidney behind it, for example. And by stacking multiple slices, you can build a 3D representation.
Now, viewing CT slices has its own strict rule, doesn't it? It's different from standard X-rays.
It is absolutely critical to get this right. For CT scans, and MRI scans too, transverse or axial slices are always viewed as if you are standing at the foot of the patient's bed, looking up towards their head. This is called an inferior view.
Inferior view. Looking up from the feet. So again, the patient's right side will be on my left on the screen.
Correct. Patient's right is on the viewer's left. Patient's left is on the viewer's right. Anterior structures are at the top of the image, posterior structures at the bottom. You must orient yourself this way every time you look at a CT or MRI axial slice.
It feels counterintuitive at first, but consistency is key. What about coronal or sagittal CT views?
Coronal views are typically viewed as if the patient is facing you, similar to a standard X-ray. Sagittal views are usually viewed from left to right, but the axial inferior view is the most fundamental convention.
Okay. CT gives us great cross-sectional detail, especially for bone and density differences. What about imaging that avoids X-rays altogether, like ultrasound?
Ultrasonography, or US, is fantastic. It uses no ionizing radiation at all. Instead, a transducer sends pulses of high-frequency sound waves into the body.
And it listens for echoes.
Exactly. The sound waves travel through tissues, but when they hit an interface, a boundary between tissues of different acoustic properties, like fluid versus soft tissue or soft tissue versus bone, some of the sound waves are reflected back as echoes. The transducer picks up these returning echoes.
And the machine turns the timing and strength of those echoes into an image.
Yes. The machine knows how long it took for the echo to return, so it can calculate the depth of the interface. The strength of the echo tells it something about the nature of the boundary. It builds up a real-time cross-sectional image based on these echoes.
What are the big advantages of ultrasound?
Several key ones. One, no ionizing radiation, which makes it incredibly safe, especially for repeated use or in sensitive populations like pregnant women and children. It's the go-to for fetal imaging. Two, it's relatively inexpensive compared to CT or MRI. Three, its portable machines can be brought right to the bedside or into the operating room. Four, it's real time. You can see movement, like a baby kicking or blood flowing.
Blood flow, how does it see that?
That uses a specific technique called Doppler ultrasonography. It takes advantage of the Doppler effect, the change in frequency of a wave when the source or reflector is moving. By analyzing the frequency shift of echoes returning from moving red blood cells, Doppler US can measure the velocity and direction of blood flow in vessels, which is invaluable for diagnosing clots, stenosis, or vascular problems.
So safe, cheap, portable, real-time, and can assess blood flow. Very versatile. Now, for the best soft tissue detail, we often turn to MRI, right? Magnetic resonance imaging.
MRI is the champion for soft tissue contrast. If you need to differentiate between gray matter and white matter in the brain, or see subtle tears in ligaments or cartilage, or examine the spinal cord in detail, MRI is usually superior to CT.
How does it achieve that without X-rays? It uses magnets and radio waves.
That's the core of it. The patient lies inside a very strong magnet. This magnetic field aligns the protons, specifically the hydrogen protons found abundantly in water and fat throughout the body. Then the machine sends in pulses of radio waves.
What do the radio waves do?
They knock the aligned protons temporarily out of alignment. When the radio wave pulse stops, the protons relax back into alignment with the magnetic field, and as they do, they emit a faint radio signal of their own.
And the machine detects those faint signals.
Yes, and crucially, the way protons relax and the signal they emit varies depending on the tissue environment they're in, how much water is present, whether it's bound or free, the surrounding molecules. Tissues like brain, muscle, fat, fluid all produce slightly different signals. The computer processes these signals to create incredibly detailed images.
That's why it's so good for the brain and spinal cord, which are mostly water and fat.
Exactly. It provides exquisite detail of soft tissue anatomy that other modalities just can't match. And remember, the viewing convention for axial MRI slices is the same as CT inferior view, looking up from the feet.
Right, inferior view. Okay, one last category. Nuclear medicine imaging. This sounds different again. Is it about structure or function?
Primarily about function. Nuclear medicine gives us a window into physiology and metabolic activity.
How does it work? It uses radioactive tracers.
Yes. Small amounts of radioactive materials, called radiopharmaceuticals or tracers, are administered to the patient, usually by injection. These tracers are designed to be taken up preferentially by certain organs or tissues, or to participate in specific metabolic processes.
So they go where the action is.
Essentially, yes. A special camera, like a gamma camera or a PT scanner, then detects the radiation being emitted from the areas where the tracer has concentrated. This creates an image that maps out the functional activity rather than just the anatomical structure.
Can you give an example?
A classic one is a PET scan, positron emission tomography. Often, a tracer like FDG, which is glucose tagged with a radioactive isotope, is used. Cancer cells, being highly metabolically active, gobble up glucose much faster than normal tissues. So tumors will concentrate the FDG and light up brightly on the PET scan, showing you where the active disease is. It can also show brain activity areas using more glucose light up.
So it's showing a metabolic hotspots. What about the bone scan mentioned in the book?
A bone scan uses a tracer that incorporates into areas of active bone remodeling or turnover, so it's extremely sensitive for detecting things like Subtle fractures, bone infections, osteomyelitis, or metastatic cancer deposits in bone, often much earlier than they'd be visible on a standard X-ray because the physiological change happens before the structural change is apparent.
Fascinating. So imaging isn't just one technique. It's a whole toolkit: X-ray for density, CT for slices, US for safe real-time views, MRI for soft tissue, and nuclear medicine for function.
That's the landscape. And understanding these tools is essential for correlating what you learn in anatomy with what you'll see in clinical practice.
Absolutely. Okay, we've got the ANS wiring and the visualization tools under our belt. Now let's finally make that transition and start our regional exploration with the back. Right. Chapter 2 begins. We're shifting from looking at systems spread throughout the body to focusing on one specific region, the back. This regional approach is how most anatomy courses and dissections are structured, right? Layer by layer.
It is. Skin, superficial fascia, deep fascia, muscles, then the skeletal framework and deeper structures. We start with the central pillar of the back, the vertebral column, or spine.
The backbone. It seems simple, but the book lists 3 really crucial and somewhat competing functions.
They are fundamental. First, and maybe most obviously, it has to protect the spinal cord and nerve roots. It forms a strong, bony conduit.
Protection function 1, what's 2?
Function 2 is support. It supports the weight of the head, the neck, the trunk, and the upper limbs, transmitting all that force down through the pelvis to the lower limbs when standing or sitting. It's the body's main load-bearing axis.
Support function 2. Makes sense why it gets bigger as you go down. What's the third function? You said it competes a bit.
Function 3 is providing an axis for movement while also maintaining posture. It needs to be rigid enough to hold us upright and provide a stable base for limb movements, but also flexible enough to allow us to bend, twist, and absorb shock during locomotion.
Rigidity and flexibility. That is a balancing act. How does it achieve both?
Through its segmented structure, it's not one solid rod. It's a stack of individual bones, the vertebrae, separated by shock-absorbing intervertebral discs. This allows movement between segments while the overall column provides stability.
How many vertebrae are we talking about?
Typically 33 vertebrae in total during early development, but in adults, some fuse, you end up with 24 distinct mobile vertebrae, the cervical, thoracic, and lumbar ones. Then below that, the sacrum is formed from 5 fused vertebrae, and the coccyx, or tailbone, is usually formed from 4 fused vertebrae.
So 24 mobile plus 9 fused in the sacrum and coccyx. Let's list the regions and numbers again.
Okay, top down. 7 cervical vertebrae in the neck, C1 to C7, then 12 thoracic vertebrae in the chest region, articulating with the ribs, T1 to T12, then 5 large lumbar vertebrae in the lower back, L1 to L5, below that the fused sacrum, S1, S5, and finally the fused coccyx, CO1, C4.
And you mentioned that support function. You can see it in the size, can't you?
Absolutely. If you look at the vertebral bodies, the main weight-bearing part, and the intervertebral discs between them, they get progressively larger and more robust as you descend from the neck, C1, down to the last lumbar vertebra, L5, reflecting the increasing amount of body weight they have to support.
Now, a huge part of clinical practice involving the back is being able to locate deep structures by feeling landmarks on the surface anatomy. The book emphasizes this with Table 2.1.
It's indispensable. You can't see through the skin, so you rely on palpable, bony landmarks to know where you are, especially in the lumbar region.
What's palpable there?
The spinous processes, those bumps you feel running down the midline of your back, are quite large and distinct in the lumbar spine, particularly if the person bends forward slightly.
But there's one specific landmark involving the hips that's incredibly important clinically, isn't there? The iliac crests.
Yes, this is a critical one. If you put your hands on your hips, the highest point of the bone you feel on each side is the iliac crest. Now imagine drawing a horizontal line connecting the highest points of both iliac crests across the patient's back.
Okay, the hip line. What does that line tell us?
That line, often called the supracristal line or Jacobi's line, reliably passes across 2 very important structures deep inside. The tip of the L4 spinous process, and perhaps even more importantly, the L4-L5 intervertebral disc space.
L4-L5 disc level. Why is knowing that exact level so crucial?
It's the landmark for performing a lumbar puncture or spinal tap safely.
How so? Why is L4-L5 safe?
Because in most adults, the solid spinal cord itself ends higher up, typically around the level of the L1 or L2 vertebra. Below L2, the vertebral canal doesn't contain the delicate spinal cord tissue anymore. Instead, it contains the cauda equina, the collection of nerve roots floating in cerebrospinal fluid, CSF, and the surrounding meninges.
So by inserting the needle at the L4-L5, level, or sometimes L3, L4, identified by the iliac crest line, you were well below the end of the spinal cord.
Exactly. The nerve roots of the cauda equina tend to float away from the needle, making the risk of direct injury to major neural tissue much, much lower. You can safely access the subarachnoid space to withdraw CSF or inject medication. That L4 landmark is arguably one of the most vital pieces of surface anatomy for procedural safety.
Definitely one to remember. Are there useful landmarks higher up, maybe using the shoulder blades?
Yes, the scapula helps orient us in the thoracic region, although its position changes a bit with arm movement. But with the arm relaxed by the side, adducted, the root of the spine of the scapula, that horizontal ridge you can feel, usually lies level with the tip of the T3 spinous process.
T3 at the scapular spine root.
Yeah.
And the bottom tip of the scapula.
The inferior angle of the scapula, again with the arm adducted, generally corresponds to the level of the T7 spinous process.
Key 7. That's often used as a landmark for listening to the lower lung fields, isn't it?
It is. It gives you a rough idea of the level of the oblique fissure of the lungs and the diaphragm. These surface landmarks, L4, T3, T7, are essential for correlating physical exam findings or imaging results to the underlying spinal levels.
Okay, so we know the overall structure, the regions, the functions, and how to find our way around using landmarks. Now let's zoom in on the building block itself, the typical vertebra.
Right, let's dissect the typical vertebra. While vertebrae differ quite a bit between regions, they share a common basic plan, as shown in Figure 2.3. Every typical vertebra has two main parts.
What are they?
Anteriorly, you have the large, spool-shaped vertebral body, which is the main weight-bearing component. Posteriorly, attached to the body, you have the vertebral arch.
The arch. That's the ring-like structure at the back.
Exactly. The arch forms the walls of the hole in the middle. It's built from several parts itself. Projecting backwards from the sides of the vertebral body are two short, strong pillars called pedicles.
Pedicles connect the arch to the body. Then what?
The pedicles then connect to two broad, flat plates of bone called laminae. The two laminae curve backwards and meet in the midline, fusing together to complete the arch. So arch equals two pedicles plus two laminae.
Body anteriorly, arch posteriorly, enclosing a central hull. And then sticking off this basic structure are various processes, right, for muscles and joints.
Correct. A typical vertebra has 7 processes extending from the vertebral arch.
7. Let's count them.
Okay. One spinous process points backwards, and often downwards, from where the two laminae meet. This is the bump you feel down your spine. Then, projecting out sideways from the junction of the pedicles and laminae are 2 transverse processes, one on each side.
So that's 3. 1 spinous, 2 transverse. What are the other 4?
The other 4 are the articular processes, or zygapophyses. There are 2 superior articular processes projecting upwards and 2 inferior articular processes projecting downwards. These have smooth surfaces called facets, where each vertebra joins, or articulates, with the vertebra above and below it.
Got it. Body, arch, pedicles plus laminae, and 7 processes. 1 spinous, 2 transverse, 4 articular. Let's look closer at the body first. Its job is weight-bearing. What's it made of?
If you slice a vertebral body open, like in Figure 2.4, you see it's mostly trabecular bone, also known as spongy or cancellous bone. It's like a meshwork of bony struts, mainly arranged vertically to resist compression, but also with horizontal connections for strength.
Spongy bone inside. What's on the outside?
Just a thin shell of hard, compact bones surrounding the trabecular core. This design makes it strong, but relatively lightweight. The extensive spongy bone, however, means it has a rich blood supply via the bone marrow within it.
Which clinically makes vertebral bodies a common site for bloodborne infections or cancer metastasis, right?
Unfortunately, yes. That rich vascular network is a double-edged sword. Now look at the top and bottom surfaces of the body where it contacts the intervertebral disc.
They look smoother, flatter.
They are. These surfaces are covered by plates of hyaline cartilage called the vertebral end plates. Around the edge of these end plates is a raised rim of smooth, dense bone called the epiphyseal rim or annular epiphysis.
What do the end plates and rims do? Just provide a smooth surface for the disc?
They do that, but the end plate is also crucial for disc health. The central part of the cartilage end plate is slightly porous. Since the intervertebral disc itself is largely avascular, has no blood supply in adults, it relies on diffusion of nutrients and oxygen from the blood vessels in the vertebral body through the end plate into the disc.
So the end plate acts like a semi-permeable membrane feeding the disc.
In essence, yes, it's vital for maintaining disc nutrition and removing waste products. Damage to the end plate can compromise disc health.
And the book mentions these epiphyseal rims fuse around age 25.
That's right. Before fusion, they represent a growth zone. This means that in adolescence, severe trauma might cause the rim to separate rather than causing a fracture through the main body, which is different from injury patterns seen in adults after fusion.
Okay, that covers the body. Now back to the arch. The arch and the back of the body surround that central hole. What's that called?
That hole within a single vertebra is the vertebral foramen.
And when you stack all the vertebrae up, the foramina align.
They align to form the continuous vertebral canal, or spinal canal. This canal is the protective bony tunnel that runs the length of the column, housing the delicate spinal cord, its surrounding meninges, blood vessels, and the nerve roots as they emerge.
So the vertebral canal protects the main cord. But how do the spinal nerves actually get out of the canal to supply the body?
That's the job of the intervertebral foramina, IVF, shown nicely in Figure 2.5. These are openings on the sides of the vertebral column between adjacent vertebrae.
How are they formed? They aren't holes within a single bone.
No, they're formed by the stacking. Look at the pedicles again. The top edge of each pedicle has a shallow dip called the superior vertebral notch, and the bottom edge has a much deeper dip called the inferior vertebral notch.
Okay, notches on the top and bottom of the pedicle.
When you stack two vertebrae, the inferior notch of the vertebra above combines with the superior notch of the vertebra below to form a complete opening, the intervertebral foramen.
Ah, so each IVF is formed by the pedicle notches of two adjacent vertebrae. And what passes through these IVFs?
This is the exit point for the spinal nerves branching off the spinal cord at each level. The dorsal root ganglion, containing sensory neuron cell bodies, also sits within or near the IVF. Blood vessels supplying the cord also use these openings.
Clinically, these IVFs sound like potential trouble spots. They're bony tunnels that nerves have to pass through.
They are major sites of pathology. Anything that narrows the IVF can compress the exiting spinal nerve or its roots. Common culprits include a herniated intervertebral disc bulging backwards and sideways, bony overgrowths called osteophytes, bone spurs, developing due to arthritis or ligament thickening.
And nerve compression there would cause pain, numbness, or weakness along the path of that specific nerve.
Exactly. That condition is called radiculopathy pathology of the nerve root, often caused by stenosis or narrowing of the intervertebral foramen. Understanding IVF anatomy is crucial for diagnosing back and limb pain.
Makes sense. Finally, let's revisit those 7 processes sticking off the arch. What are their main functions?
The spinous and transverse processes primarily act as levers for muscle and ligament attachment. The large back muscles pull on these processes to extend, rotate, and laterally bend the spine. The size and orientation of the processes influence the mechanical advantage these muscles have.
So muscle attachment points and levers. What about the articular processes, the zygapophyses? They form joints, right?
Yes, the superior articular facets of one vertebra articulate with the inferior articular facets of the vertebra above it, forming synovial joints called zygapophyseal joints, or facet joints. These guide and also limit movement between vertebrae.
How do they limit movement?
The key is the orientation of the articular facets. The direction the facet surfaces face varies significantly between the cervical, thoracic, and lumbar regions, and this orientation dictates the type of motion that is freely allowed versus the type that is restricted in each region.
So the shape of the joint surfaces determines the function. Can you give an example?
Absolutely. Take the thoracic spine. The articular facets here are oriented mainly in the frontal plane, almost vertically. Think of two flat plates sliding past each other. This allows for a good deal of rotation and also some lateral bending.
Thoracic facets allow rotation. What about the lumbar spine? It carries much more weight.
In the lumbar spine, the facets are oriented much more sagittally. The superior facets tend to face medially, and the inferior facets face laterally, almost like they're cupped or interlocked.
What does that sagittal orientation do?
It strongly facilitates flexion, bending forward, and extension, bending backward. But it acts like a bony block that severely restricts rotation. This helps stabilize the lumbar spine and protect the discs from twisting forces under heavy load.
Wow, so just changing the angle of those little joint surfaces dramatically alters the movement capabilities of that whole spinal region. Form dictates function perfectly.
It's a beautiful example of biomechanical design. Understanding the typical vertebra body for weight, arch for protection, processes for muscle leverage, and articular facets for guiding movement is the absolute foundation for understanding the specialized features and clinical problems of each spinal region, which we'll get into next time.
Okay, that brings us to the end of this deep dive, episode 3 of Bookfulness. We covered a lot of ground today. We started by untangling the autonomic nervous system, nailing down that crucial two-neuron pathway, and contrasting the widespread sympathetic system with the precise parasympathetic system.
We saw how sympathetic signals originate centrally, T1L2, diverge massively, and use gray rhymi or periarterial plexuses for distribution, with the unique suprarenal gland exception. And how parasympathetic signals, craniosacral, use long preganglionic fibers and short postganglionic fibers for localized control.
Then we moved to medical imaging, demystifying the basics of X-rays, radiopaque versus radiolucent, CT, cross-sections, inferior view, MRI, soft tissue detail, inferior view, ultrasound, safe real-time, and nuclear medicine, function physiology.
We stress those viewing conventions patient-facing you for standard films, looking up from the feet for CT-MRI axial slices.
And finally, we launched into regional anatomy with Chapter 2, getting an overview of the back and vertebral column. We discussed its functions, protection, support, movement, its regions, and the critical importance of surface landmarks like the L4 level found via the iliac crests.
And we dissected the typical vertebra, identifying the body, arch components, pedicles, laminae, the 7 processes, and how features like the vertebral canal, intervertebral foramina, and especially the orientation of articular facets relate directly to function and clinical issues like nerve compression and regional movement patterns.
Now for a final thought to take away from today's session.
Consider this. We spent a lot of time tracing the complex, multi-neuron branching pathways the sympathetic nervous system uses just to control something seemingly simple, like sweating or blood vessel diameter all over the body. It needs ganglia, rami communicantes, intricate plexuses.
Right, it seems quite convoluted.
Now contrast that with the system controlling the incredibly precise voluntary movements of your fingers, as you say, play an instrument or type. That uses a direct, single upper motor neuron synapsing on a lower motor neuron, which goes straight to the muscle. It's relatively simple wiring for incredibly complex conscious action, yet the unconscious background regulation via the ANS requires this much more elaborate, multi-layered relay system. It really highlights how different the body's design priorities are for automatic survival functions versus voluntary interaction with the world. The complexity isn't always where you'd expect it.
That's a great point, the hidden complexity of the automatic. Something to definitely think about. Next time, we'll build directly on this foundation. We'll dive into the specific, unique features of the vertebrae in each region, cervical, thoracic, lumbar, sacral, and coccygeal, and explore the joints that hold them together.
Looking forward to it. Thanks for listening to Bookfulness.